What's being presented here is just a part of it to do with acute promyelocytic leukemia. And this is quite a large phase 3 trial testing whether you can give what we call a chemo-free option of arsenic and ATRA instead of standard of care, which is chemotherapy plus ATRA, and whether indeed you can give it to the high-risk patients, those who present with a white count greater than 10. So we know from a more or less contemporary study conducted in Italy and Germany that low-risk patients, lower than 10,000 at presentation, 75% of all cases, have about a 90% survival just by using arsenic and ATRA. That combination was developed in the MD Anderson, but that was the first published randomized trial. And then last year we published our trial, which was a similar sized trial. The difference was a number of differences. First, we included high-risk patients, but we gave them additional injection at the beginning of gemtuzumab ozogamicin, which we happen to have available. It's not a licensed drug. And maybe an anthracycline would do just as well. But we found that these patients also did very well. So our survival was also about 90%, even in the high risk. And the interesting thing was that once these patients got to out 30 days, nothing further happened to them. There were no relapses. So if you give a patient ATRA and arsenic, you don't have to give them any other treatment, unless they're high risk, then you give them a dose or two of an anthracycline probably. And you don't need to do molecular monitoring because they're not going to relapse. Whereas you do have to do that with the conventional chemo. So that was that. The second issue is how much arsenic trioxide do you need? In Europe it's important because it's expensive. And our schedule was different from the Italian-German one. They gave it every day after the patient was in remission, and we gave it twice a week, which you could argue was more suitable for patients not coming to get an injection every couple of days. So what's being presented here at the ASH meeting by Dr. Russell is the longer follow-up, showing that the results haven't changed since the publication 18 months ago. So I think that's a new way to treat APL. There are a number of questions. Do we know how much arsenic they really need to have? We don't think they need maintenance. Can children have this sort of approach? Is the dose and schedule right? Would there be room for oral arsenic, which there is some in the early stages of development? And again, that's unlikely to compete from an efficacious point of view, but it is likely to be more convenient for the patient. So these are the things in APL.